Hi, my name is Samantha Modrak, and I'm going to be doing a head, eyes, ears, nose, and throat assessment on my patient, Alec. Thanks for being here today. Are you ready to get started?
Yes.
Okay. Hi, my name is Sam. I'm going to be your nurse today. Can you just tell me your name and birthday, please?
Alec Wagner, July 2nd, 1989.
I'm going to check your ID band. Perfect. Just so you know, I just washed my hands prior to coming into the room, so I'm nice and clean. So we're first, like I said, we're going to do an eyes, ears, nose, and throat inspection today. We're supposed to have an otoscope and an ophthalmoscope, but we don't have that, so we're just going to talk about those parts. So we're just going to look at the general appearance of your head and neck and make sure everything looks like it's in symmetry. The head should be straight. There should be no drooping on either side. That would indicate a stroke, so it doesn't look like you're having a stroke. That's great. Your neck looks fine. We're looking to inspect the neck. There's no bulging, and there's no vessels with excessive palpitations. We're going to press on the sinuses above your eyebrows. We're still looking for symmetry. We're checking the cheeks for the maxillary sinuses. We just checked the frontal sinus on your eyebrows. There's no tenderness, right?
No.
Okay. We have to palpate lymph nodes with the flat part of 2 fingers, and we're going to do the periauricular, which are the front of your ears. We're going to do the tonsillar, which are under the back of your jaw. We're going to do the cervical, which are up and down the side of the neck, and the post-cervical behind the sternocleidomastoid. So that all feels good. Underneath the jaw, looking at the submental, and behind the neck for the occipital at the base of the neck. And then we're going to check the supraclavicular, which is the indentation right above your clavicle. And I don't feel any lymph nodes, which is normal, so no lymphadenopathy. We're going to look at your trachea and find your sternal notch. We have our finger and forefinger there. It looks like it's centered, so there's no tracheal deviation. Push on your thyroid glands on the side of your neck. If you could just swallow for me. Okay. And then we don't see any enlarged thyroid glands or goiters. So that's good. So the next thing we move to is your eyes. We don't have an ophthalmoscope, so we won't be doing that part. If we had it, we would use it to check our red reflex on both eyes for reflection on the back of the retina. If there is white, that could indicate there is cataract. We want to check each pupil and make sure they're equal round and reactive to light. Oops, and I dropped your glasses. I'm so sorry about that. So I don't have a ophthalmoscope, but I have a light on my phone. So we're just going to check both sides. If you could just look straight at me, we're going to shine a light on both sides. Okay. We're looking for pupil constriction. So we saw the same on both sides. Both the pupils are equal in size, and they're round, reactive to light, directly and consensually. So we want to check accommodation. So we're going to have our patient look off into the distance, and then we're going to put 3 fingers in front of your face, and your pupils are going from dilated to constriction when looking close to pupils constriction and converged, which is accommodation. So go ahead and look off into the distance, and then we'll put 3 fingers, and now look at these. Yay, so that worked good. Another thing we're going to look at is your eyelashes. We're going to check your sclera, which should be white. Can you just pull your eyelids down? And we're looking at the conjunctiva, and that's pink. They're not red, they're not infected, and they're not draining. Yay. Your ears we would look at. We don't have an otoscope, but if we had one, we would put on a speculum and check the ears. We would look at the ears, the position of the ears. We would look for obvious lesions on your ears, which I don't see any. I'm going to touch your earlobes. Do you have any pain?
No, I do not.
Okay, if you have pain, that could mean that you have swimmer's ear. And if we were doing like an inside exam, we would pull your ear back because you're adult, so we would pull up and back. We put the otoscope in your ear. We would look for your tympanic membrane, which is pearly gray. We would see a light reflex on the right ear. We would look for the 5 o'clock spot. For the cone of light, it should be clear. And on the left ear, we'd do the same, and it should be at the 7 o'clock spot. The cone of light would be at the 7 o'clock spot. So, like I said, we don't have the proper tools here at home, so we can't do that. Um, for your nose, we just want to look at your nose. It's straight on your face. There's no deformities. If you could just occlude one side and sniff, we're doing a patency test. And then if you could do the other side, that would be great. Okay, we're going to look at your nose. We're just looking for any redness or a deviated septum. That looks good. Now I would wash my hands because I touched your nose. Lots of germs in your nose. For your mouth, we're going to have you open your mouth and stick out your tongue and say, ah.
Ah.
Yay. Okay. Can you raise your tongue for me? We're looking at the cheeks. If you can pull down your bottom lip, we want to look at your lip and your teeth condition. So that looks good. When he said ah, his uvula rose. So that's good. There's no redness or drainage in his throat. If we were going to use a tongue blade, we would be careful because we wouldn't want to hit your gag reflex and have you projectile vomit on me. So that's the first part of the head, eye, ear, nose, and throat exam. And then just for like the basic eye exam, it would be pretty thorough. We don't have slit lamps for that. I'm just going to kind of talk about it. The OD, or the right eye, oculus dexter, and the OS is the left eye, and that's the oculus sinister. OU would be oculus urtique for both eyes. Tonotomy is represented by a T that checks the pressure. And VCC, we would write with if you had corrective glasses, which he does, and VCS would be without correction. We would check his best corrected visual acuity, and that would be their best vision with their corrected lenses. So the initial exam, we would check the external areas of the eye, the motility alignment of the eye, the visual field deficits, check pupils, check visual acuity, check the pressure of the eye, color testing, if you have equipment you can do, which we don't. So the external exam, we're going to look for ptosis or exophthalmos, if there's any lacerations on the eye, any ecchymosis, edema, periorbital edema, any masses. His eyes are normal, so he doesn't have any of that, but if he did, we would note where it is and how big it is. The motility alignment, we would have both eyes open, and we would have him follow a finger or a pen using only his eyes, and we'd have our finger about 14 inches away from his face, and we would have the patient trace an H, and we're going to observe his eye movements, and we're checking for nystagmus, and we would note where the nystagmus is going, and if there are any gaze palsies, and if his eyes are moving in a conjunctive manner. So we'll just do that real quick. So we're going to have him follow your finger with an H. Okay, so no nystagmus, no gaze palsies. His eyes are moving together like they're supposed to. So that's good. We would do visual field testing. So me and my patient are sitting at the same level, which is good. We're going to have you cover your left eye, and I'm going to cover my right eye. And we're going to have you trace my finger up and down. Okay. And can you tell me when you see my finger?
Two.
Okay.
I see.
Okay. And I'm using my same eye, and I can kind of tell, we're kind of gauging whether he's seeing it when I'm seeing, so that's good. So if we flip, tell me when you see your finger.
I see.
Okay.
I see.
Okay. So he's about the same as me, so that's good. And then we're going to check to make sure that he has vision in all 4 quadrants. So I'm going to hold up 2 fingers in each 4 quadrant to make sure he has vision in all 4 quadrants. So can you see my fingers over here?
2.
How about up here?
2.
How about over here? How about over here?
And 2.
Perfect. Yay. Okay, so then we're going to check the pupils. And we kind of already did this already. His pupils are equally round. They're reactive. They're brisk. He doesn't have any pupillary deficits or defects. We would use a swinging flashlight test to check for photophobia, and we would do that by shining a pen light into his eye, which my camera light is this that we have, and that's fine. We don't have a Snellen chart to check for visual acuity. If we had one and he couldn't see the big E on the Snellen chart, we'd have him count fingers at 3 feet. If he couldn't see fingers, we'd ask him to check for hand motion and how many feet he could see a hand. And then if he couldn't see the hand, we would check to see if he could see light. And that would be called light perception or no light perception. If we had a tono pen, we could check the pressure of his eyes. Normal pressure is 10 to 21 milligrams of mercury. We'd put on a sterile color and touch the tono pen to his cornea after numbing his cornea. Other tests we could do would be color plates. That checks color blindness. That's the one that if you can't see the numbers, then you're having trouble seeing colors. We could also check for color saturation, sensitivity to red colors, maybe in the optic nerve is damaged, just maybe the reds might not look so bright. And we could also do the fly test to check for 3D vision, and that test basically requires you to have vision in both of your eyes. We could check the fundus exam, which we'd use a panoptic if available, or we could use an ophthalmoscope. That checks the optic disc. We would look for no exudates on the fundus, which we would want it to be pink, orange with no pale spots or hemorrhages. We would check for papillal edema, which if it's fuzzy, it may indicate increased cranial pressure. It could also tell us if it's hypertensive hemorrhages, and it may show blood on the fundus, which would be hypertensive retinopathy. If we had a slip lamp, which we don't have, we'd want to be systematic. We'd go from the front to the back or the outside of the inside of the eye. We would look at the lids and lashes with a slit lamp. We would check sclera and conjunctiva. Is it red or infected? Where? We would look for spots and masses. We would check for conjunctival hemorrhage. And then any abnormalities, we'd use a clock hours to describe injuries. Chemosis is the swelling of the conjunctiva, so we check for that. We check the cornea, which we would want to be crisp and clear with crisp edges. If it's edematous, it might be blurry. Arcus is the white around the cornea. This is something that occurs with age, like in the 60s or 70s. It's deposits of cholesterol. That could be a indication of Wilson's disease, which is a deficit of copper in the cornea. We look at the anterior chamber. Is it filled with aqueous humor that bathes the cornea and keeps it nourished? Sometimes with infection or trauma, you can get blood or pus in the anterior chamber, and that's called hypnemia. We check the iris, which is the colored part of the eye. We would look for any hamartomas or nodules, any tears or surgical tears. We'd look at the lens, and that's the most interior structure. Yellow means the start of a cataract. Patient may complain that white stuff doesn't look as white, or everything kind of looks brown. Cataracts are opaque white, and they can be usually fixed with surgery. And then the last part of this is the hearing part. We'd always want to explain to our patient what we're doing before we do it. We're going to stand behind you. We're going to whisper some words. Or I'm going to knock my cabinet over. Alright, so can you cover this ear? We're going to repeat 3. I'm going to whisper 3 numbers into your ear, and then I want you to say them back to me, okay? 99.
99.
72.
72.
64.
64.
Okay, now we're going to do it on the other side. 79.
79.
54.
54.
92.
92.
Okay, so that's good. And then if we had a tuning fork for the Rhines test, we would ping it on our knee or tap on it, and then we would locate the mastoid process on the back of the ear, and we would move the fork around and ask where they could hear the sound best. If the bone conduction is greater than the air conduction, it indicates a potential conductive deafness in that ear. So we don't have a tuning fork, so we can't do that. That's why I'm explaining it. In the Weber's test, we would ping the tuning fork and place it on the center of their forehead, and then we would ask the patient where they hear the sound best. In the middle is normal. If the Weber's test sound appears quieter in the ear with sensory neural deficits, that usually means a sensory neural deafness. And I think that's it. What do you think? All right. Go Steelers.